ఇది ఒక్కసారి షేర్ దేవు. Good morning, everyone, and welcome to today's wonderful morning with Dr. Murli Bharadwaj. So, there are 118 topics in general medicine, of which 31 topics are from cardiology, which we are in the journey of finishing today. So, the first one is myocardial infarction. So, what are the two types of infarction, doctor? One is transmural MI, entire thickness of the myocardium. Second is subendocardial infarction. So whenever transmural MI, as you can see here, it reflects on the ECG as a elevation of the ST segment, whereas subendocardial MI is only partial thickness. That's the reason it presents as a ST depression is what we need to remember. You know the circulation of the coronaries. We have left coronary artery, right coronary artery. In that you have left anterior descending and circumflex, which are the branches of left coronary artery. So left anterior descending artery occlusion, which is the branch of the left coronary artery, is the most common coronary which is involved. That's the reason. What is the other name given for the left anterior descending artery? Widow's artery. Because of that, the man dies out of heart attack and the woman is widowed, or vice versa. Now, there are certain common clinical vignettes you need to know. Anybody with chest pain, profusely sweating along with dyspnea, classic triad of acute MI. But in diabetic, elderly patients, there is no pain. That's called painless MI. Suddenly they wake up the daddy and found that he is being dead. That is painless MI. Similarly, you have a left ventricle, right ventricle. Left ventricle pumps into body but receives from lungs. Right ventricle receives from body and pumps into lungs. So when left ventricle fails, lungs cannot be able to drain into left atrium. That's the reason the lungs develop congestion and pulmonary edema. See, lungs drain through pulmonary vein into left atrium, into left ventricle. If left ventricular infarction is there, left ventricular pressure increases, left atrium pressure, which is behind it, increase. Pulmonary vein pressure, which is behind left atrium, will increase, and that lead to pulmonary edema. So dyspnea, pulmonary edema is the presentation of left ventricular infarction. Whereas right ventricle is drained by right atrium. What drains into right atrium? SVC, IVC. So any right ventricular infarction will lead to congestion in right atrium, that lead to congestion in pulmonary, SVC, IVC, that lead to development of raised JVP. So hypotension, raised JVP, but clear lung fields is equal to RV infarction. Lungs flooded with pulmonary edema with shortness of breath is the presentation of left ventricular infarction. So you need to know the difference between LV infarction and RV infarction. Are we clear? We are not? 1 minute. I'll just show you something. I need actually okay. I need a heart to show you that. See, this is heart, okay? Left atrium, and this is LV. LV drains into aorta. RV drains into pulmonary artery. Pulmonary artery goes and forms pulmonary capillaries. In the lungs, it gets oxygenated. That pulmonary vein comes and drains into LA. This much clear? Whereas our entire body brings the blood, SVC and IVC. They both bring blood into right atrium, which will go into right ventricle. When the LV fail or infarction is there, it can't pump the blood into aorta. That lead to pressure in the left atrium to increase. And that will increase the pressure in the pulmonary vein. That lead to pressure in the pulmonary capillary. That lead to pulmonary edema. So dyspnea with a lot of crepitations of pulmonary edema in the lungs is equal to LV infarction. RV infarction, it is the SVC, IVC which are draining into the right atrium, which is going into right ventricle. That's the reason whenever RV infarcts, the pressure in the, because it is unable to pump into pulmonary artery, the pressure in the right atrium will increase. That will increase the pressure in SVC and IVC. That's the reason there will be pedal edema, raised JVP, jugular venous, because jugular veins drain into the right atrium. Jugular vein comes from your SVC to jugular vein to right atrium. So jugular vein distended is the typical feature which you see in case of the right ventricular infarction is what we need to basically remember. Now, in the people who take cocaine lead to the coronary blood vessel vasospasm, and that lead to development of myocardial infarction. That's the reason in the case of myocardial infarction, you should also be observant about the possibility of any cocaine drug abuser is what we need to remember. But in this regard, you need to know, why do we give beta blockers in case of myocardial infarction? If you give beta blocker, will it slow the heart rate or increase the heart rate? Decrease. Beta blocker, atenolol, metoprolol, propranolol, all lols, they decrease the heart rate. If you decrease the heart rate, will the myocardial oxygen demand will be more or less? It will be less. If you are running, if the heart rate is slow, myocardial oxygen demand decreases. And is that good or bad when the coronary insufficiency is there? Good. If the myocardial heart key oxygen requirement decreases, even if the blood flow to the heart is less in case of MI, still heart survives. So the whole purpose of giving beta blocker in case of myocardial infarction is slow the heart rate, decrease the myocardial oxygen demand, and by doing so, what are you doing? You are helping the heart whose blood flow in the coronaries has decreased. But never use beta blockers if the coronary insufficiency, myocardial infarction, is because of cocaine, is the favorite question of the examiner. Clear? Then, a patient who had MI suddenly collapsed with hypotension. What is the underlying cause? Ventricular fibrillation. Ventricular fibrillation. Why? Whenever the myocardium suffers ischemia, ischemia means decreased blood flow. There's a decreased oxygen. Decreased oxygen will irritate the myocardium, and that lead to development of arrhythmia, and ventricular fibrillation is the cause. So what is the most common cause of the death in all the patients of myocardial infarction before they come to hospital? Why do they die in the home? It is because of ventricular fibrillation is what you need to basically remember. Clear? Now, it's very common as an intern, you have to look at the ECG and decide heart attack in a person who has got chest pain. We will take ECG separately, but for now try to learn. You know how many waves are there in ECG? First you are having a P wave, then QRS, then a T wave. P wave is atrial depolarization, QRS is ventricular depolarization, T wave is ventricular repolarization. What is Q? What is R and S? Any positive wave is called R. Any negative before positive wave is called Q. Any negative after the R wave is called S wave. Put it QRS, which is the sign of ventricular depolarization. So whenever myocardial infarction is there, the first change to happen is hyperacute T waves. What do you mean by hyperacute T waves? Typically, the T wave become tall. T wave become tall. That is called hyperacute T wave. The earliest ECG change in MI is what you need to remember. There is one more condition where tall T wave will appear. That is when patient has hyperkalemia. Is another condition leading to tall T wave. But what is the difference between the tall T wave in both the cases? Symmetrical tall T wave is the feature of hyperkalemia. Asymmetrical means this is like this and this is like this. The two limbs of the T wave. Asymmetrical tall T wave is the feature of MI. Symmetrical tall T wave is the feature of hyperkalemia is what you need to remember. Second, after hyperacute T waves, what will happen? ST segment. S means end of the S wave to the start of the T wave. That is called, what is the segment? What is the wave in ECG? This isoelectric line is called segment. And you are having a wave. Okay. So what is the meaning of interval? In interval, you will include one wave plus one segment. So there are two intervals you need to know. One is called PR interval. What is the meaning of PR interval? Starting of the P wave, including P wave, plus the PR segment until the start of the QRS. You call it as PR interval. What is PR segment? End of the P wave to the start of the QRS. The isoelectric segment is called PR segment. So you know PR segment, PR interval. Then what is QT interval? Start of the QRS complex, including QRS complex, until the start of the T wave, including the QT segment. That is called QT interval. QT interval include QRS complex plus QT segment. So in this, from the end of the S wave to the beginning of the T wave, you call it as ST segment. So this ST segment is elevated, which is an indication of a transmural injury. If it is subendocardial injury, what will happen to ST? ST segment will depress. Okay, so you can see here, this is, here you are able to appreciate. See, this is isoelectric line. This is QRS complex, end of S. And here the start of the T. Between the two, you have this ST segment that is elevated. You can also appreciate here. See, this is ST segment, this part. This part. Can you appreciate? This ST segment is elevated. Elevated. So ST segment elevation indicative of transmural injury is the next thing. Then over a period of time, the myocardium develops a scar because of infarction. And then appear the Q waves. What is the meaning of Q wave? Any negative wave before the positive R wave is called Q wave. So typically Q waves are an indication of formation of a scar. Normally you will not have Q wave. Only you will have R and S. But appearance of the Q wave is an indication of a irreversible necrosis and scar formation is what you need to remember. Clear, doctor? Now, if you look at the heart, right? Heart has an anterior aspect. Heart has a lateral aspect. Heart has an inferior aspect. The three aspects, right? So the three aspects of the heart. So we put leads. They are called precordial leads. 6 leads. V1, V2 on the right side. V3, V4 on the middle. V5, V6 on the left side. So accordingly, all these are looking at which aspect of the heart is the front of the heart. Heart is a globe. Global is like a jug, water jug. In the front of the heart, you have V1, V2 looking at the, they're there on the right side. V3, V4, they're almost on the interventricular septum, anteriorly. V5, V6 is there in the left side. So in this, V1, V2, V3, V4 are called anterior leads. Now, in the heart, if you look, is right ventricle more anterior or left ventricle more anterior? Guess it. Right ventricle is more anterior. Immediately behind your sternum, you have the right ventricle. Tick, 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 tick. Choli ke piche kya hai? Choli ke piche. You are having left ventricle and left atrium. And what is the most posterior aspect of the heart? Left atrium is the most posterior aspect of the heart. Okay, so when ST elevation is there in V1, V2, V3, V4 leads in this V1, V2, V3, V4 in this 4 leads, then that indicates anterior wall MI, which typically happens with the left anterior descending artery occlusion. Then 3 leads look at the inferior aspect of the heart. What are they? Lead 2. Here you have the lead 2. You have the lead 3, and here you are having AVF. So totally, what is the 12 lead ECG? Lead 1, lead 2, lead 3. AVL, AVR, AVF. V1, V2, V3, V4, V5, V6. V1 to V6 are precordial leads by putting the leads on the front of the chest. How do you get lead 1, 2, 3, AVF, AVR, AVL? They are called limb leads. You connect the limbs. Okay? For now, understand this. Later, we'll go in detail in ECG. Okay? So, 2, 3 AVF, inferior leads. They're looking at the inferior part of the heart. Inferior part of the heart is supplied by right coronary artery. Anterior part of the heart is covered by left anterior descending artery. Okay. So anterior wall MI, V1 to V4, left anterior descending, 2, 3 AVF, ST elevation, inferior wall MI with RCA. It is the right coronary artery which is occluded. You should also remember we have a gatekeeper between atria and ventricles. What is that? AV node. So all atrial signals before they reach ventricle are gated by AV node. It is like a chaprassi opposite principal office. You have to bribe him to go to principal office. So left atrium, atria, ventricles. इनके बीच में AV node. So the purpose of the AV node is what? Atria should depolarize and contract, followed by ventricular depolarization and contraction. Why? When atria depolarize and contract, they are pushing the blood into ventricle. That time ventricle should receive and relax, not contract. After the atrial contraction is over, then ventricle already fully filled with the blood need to undergo contraction. In order to create that coordination, God created a AV node between atria and ventricle, so that He will let the atria contraction when it is occurring, He will make ventricle relax and not depolarize. So this AV node is supplied by right coronary artery. So whenever right coronary artery occlusion is there, then it will cause this AV node to become completely blocked. That means it won't let any of the atrial depolarization to pass into the ventricle. And that situation is called AV block. So AV block is a typical feature whenever there is any inferior wall MI, because inferior wall MI is supplied by, inferior wall is supplied by RCA, which also is supplying the AV node, is what you have to basically remember. Clear? These are the key points you need to know about the ECG in MI. Now let us quickly look, doctor. This is the normal morphology. What is this? P wave. What is this? QRS. This is T wave. What is this called? This T wave become asymmetrically big in size. Hyperacute T wave's earliest feature. Then there is a ST elevation which will occur. After that, this T wave is there, no? That undergoes inversion over a period of time. And there is appearance of a, before R wave, a deep Q wave. If you see the people who had MI long days ago, you will find this deep Q wave. Later, ST elevation will become normalized. And finally, what will be there for a patient? Deep Q waves are the only sign that जमाने के पहले इनको MI हो गया बोल के ओल्ड MI को पहचानने के लिए Q waves, deep Q waves are a important indicator. Now somebody is having the chest pain, right, doctor? So can you check, Manu, is the voice loud and clear for online? So, what are the biomarkers? There are some enzymes which will elevate troponin, CKMB, creatinine kinase MB. They are the two important. Troponin, it rises within 3 to 4 hours. It is the most specific marker that somebody's chest pain is due to MI, not because of acidity. Okay. So we do TROP kit. So you will take one blood sample and then check whether troponin positive bedside, so that you will be knowing whether he had MI. CKMB rises 4 to 6 hours, right? But one important point you need to know. If you look at the CKMB, it rises and immediately falls. Whereas, if you look at the troponin, it will rise and remain raised for a longer duration of time. So somebody had MI, right? Within few weeks, he once more had another MI. Will you depend on CKMB rise or troponin rise? After, on 8th day, one more MI happened. But the first MI's troponin is still elevated. So you can't depend on troponin. Whereas the CKMB of the first MI is expected to fall. So when there is a reinfarction, if there is a reinfarction, if at all, the CKMB once more elevated on 10th day, 11th day, then that is a second MI. Got it right? First girlfriend is very sticky. She is not leaving. Second time romance हो गया. बोल के कैसे समझ में आएगा? फर्स्ट गर्लफ्रेंड को देखे तो समझ में नहीं आएगा. Her roommate है CKMB. It is still first time rise हुआ. अभी second time भी rise हुआ. That's the reason. What is the rule, doctor? CKMB is useful for reinfarction. Troponin is useful for first time MI. When there is a earliest rise is troponin, which is most specific marker, is what you need to basically remember. So how do you manage MI? MONA. What is MONA? M for morphine, O for oxygen, N for nitrates, A for aspirin. So aspirin, पहला मुंह open करके एक aspirin डालो. First drug reduces mortality if you put aspirin as early as you can. Second, nitroglycerin. Why nitroglycerin is good in MI? Typically, nitroglycerin is a vasodilator. If the veins dilate, what will happen? All blood remain in veins. And the blood coming to heart decreases. If that's called preload. If the preload decreases to the heart, right, then heart requires very little oxygen. So nitroglycerin decreases the preload, decreases the myocardial oxygen demand, and relieves the ischemia. I mean, it doesn't relieve ischemia, but it will decrease the oxygen demand in spite of ischemia. Then another important thing is, very important thing, lifelong you should remember as a clinician. Left ventricle, whenever infarction is there, what do you have? Pulmonary edema. Right ventricular infarction, whenever it is there, right ventricular infarction, the whole body's blood which is supposed to go into right ventricle and get pumped out to go to lungs is affected. That's the reason hypotension is a feature of right ventricular infarction. Dyspnea is a feature of left ventricular infarction. So how do you relieve dyspnea and pulmonary edema? you need to give diuretic. You studied in pharmacology, right? Loop diuretics, etc. Furosemide, torsemide. You need to give when there is any left ventricular infarction. But in right ventricular infarction, already there is hypotension. You can't give a diuretic. You are worsening the hypotension. So what you need to give? You need to give fluids. 1 liter, 2 liter, 3 liter. Tuck, 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 it should run. Why? If you pass lot of fluids, when the right ventricle is infarcted, even if it is infarcted, all this fluid enter into right ventricle and it become distended. What did Frank Starling law says in physiology? The more you distend the myocardium, the stronger it will contract and push the blood. That's the reason the treatment of right ventricular infarction is fluid lagao, fluid lagao, fluid lagao. Left ventricular infarction is diuretic de do, decongest karo, fluid nikal do, body say. That is left ventricular infarction. But if you do opposite, what will happen? God started the myocardial infarction and doctor completed it. Lungs la full congestion, pulmonary edema unnavనికి fluid ఇచ్చిందనుకోండి చచ్చిపోతాడు. He'll die. Right? Whereas a guy who is having hypotension with right ventricular infarction, instead of giving fluids, if you give diuretic, he will die. So, doctor is called God's messenger because God begins myocardial infarction and Dr. Goodillingham will make sure the patient dies by giving diuretics in RV failure and fluids in LV failure is fatal mistake, unexcusable. Okay, now reperfusion, the next thing. So myocardial infarction is because of a decreased blood flow to the heart. In the coronaries, there is an atheroma, and that is causing the occlusion of the blood flow. So you need to break that clot, break that atheroma, and revascularize the blood vessel. What are the two options available? One is called percutaneous coronary angioplasty. So that's called percutaneous coronary intervention. Second is you give a thrombolytic which breaks the clot, like streptokinase. So within how much time you should give PCI? Less than 90 minutes is the golden hour. Always remember in the myocardial infarction, minute is equal to muscle is what you need to basically remember. Minute is equal to every minute you are saving the muscle. If the cath lab is not there, nowadays cath lab is there everywhere. Once upon a time it used to be only in Hyderabad. So then you need to do thrombolysis. When will thrombolysis and breaking the clot in the coronary will help you? If you do it within 12 hours, is what you have to basically remember. So now what is the drug therapy? What is the logic in giving that? We give the beta blockers, metoprolol, bisoprolol, carvedilol. All of them they decrease the heart rate, they decrease myocardial oxygen demand, they decrease the tendency for arrhythmias. That's the reason we give beta blocker. But there are three scenarios. Don't give beta blocker in MI. Number one, if the patient is in shock, if the patient has AV block, AV node is made more refractory by giving a beta blocker. So in infinimal MIs, you have AV block. So shock, AV block, cocaine users, avoid the beta blockers. We give ACE inhibitors. ACE inhibitors will decrease the remodeling of the heart, right? And that will decrease the mortality. See, whenever a heart suffers ischemia, there is a scar formation. That scar formation will try to create remodeling of the heart, which will make the heart contraction lost, myocardial contractility affected. So if you give ACE inhibitors, they decrease the remodeling and they decrease the mortality. So what are the ACE inhibitors that you know? Enalapril, right? Similarly, ARBs, angiotensin receptor blockers like telmisartan, losartan, etc. They all. Then we all give statins. Atorvastatin, rosuvastatin, any statin is one and same. Only the drug company's branding, right? So what will statins will do? They stabilize the plaques. Statins decrease cholesterol, right? So the plaque is made up of cholesterol, plug, eaten from chicken biryani and mutton biryani, right? So the plaque stabilization they will do and prevent recurrence. So if somebody has hypertension, somebody has diabetes, what you need to do? In future, you have to prevent heart attacks and stroke. Somebody today diagnosed with diabetes. And then you start 10 milligram rosuvastatin. That is called primary prevention. आज डायबिटीज आया, कल के दिन उनको हार्ट अटैक नहीं आना, बोले तो क्या देना? Rosuvastatin. Don't forget that. Right? Every neighbor, every fourth person has diabetes today. So you need to be knowing the protocol. But already if heart attack comes, MI came, then you give statin 40 milligrams. That is called secondary prevention. Try to remember the difference. Then we give a double antiplatelet therapy. What is double antiplatelet? Aspirin, clopidogrel. Together when you give clopidogrel, P2Y12, it acts on P2Y12 receptor. So aspirin plus P2Y12, double antiplatelet therapy prevents the, if you put an angioplasty and stent, it will prevent the stent thrombosis and it prevents the future thrombus, right? So summarize, doctor, what is the drug logic? Beta blockers decrease oxygen demand and decrease arrhythmias, but avoid them in shock, AV block and cocaine use. ACE inhibitors, statins and double antiplatelet therapy. Now what are the complications of MI? The most common cause for the early death after MI is because of the ventricular fibrillation. Similarly, you have papillary muscle. What will papillary muscle will do? It will hold the mitral valve. Mitral valve, when the ventricle contracts, no, the mitral valve has a tendency to prolapse into atria, which is above ventricles. So the papillary muscle will pull it down. But in MI, this papillary muscle will suffer from ischemia and it get ruptured. And when the ventricle is contracting, what will happen to the mitral valve? It will prolapse and that lead to mitral regurgitation, which is a complication. Okay. Similarly, the ventricle septum between left and right ventricles, it will suffer ischemia and it lead to ventricular septal defect and rupture. It takes about typically on the 3rd to 5th day. You know, congenitally there is a ASD, VSD. Acquired form of VSD is in MI. In MI, the interventricular septum, whenever it suffers ischemic injury, a hole forms. That acquired VSD will lead to shock. Why shock? Because left ventricle is supposed to contract and push blood into aorta. But due to the VSD, the blood will move into right and the cardiac output will diminish and that lead to shock, which is a typical complication on 3rd to 5th day. Whenever there is a huge infarct of van der Waals, the whole wall become thinned out due to ischemic necrosis. Remember, ischemia is decreased blood flow. Infarction is necrosis. Right? Kullipote, infarction. Blood dagite, ischemia. Right? So that under wall weaken and it will rupture, which can be a complication that lead to blood to move into the pericardium, from the heart into the pericardium, pericardial space. And that blood in the pericardium will further compress the heart, leading to cardiac tamponade. So free wall ruptured with tamponade and sudden death are the features in MI is what you need to remember. Then, over a period of time, after a few days, there is an autoimmune reaction in MI that lead to pericardial inflammation. That is called Dressler's syndrome. What is that Dressler's syndrome? Post-MI, after a few weeks, there is an autoimmune reaction that lead to development of the pericarditis, which is called Dressler's syndrome. So now, doctor, few things you need to be very emphatically sure. Inferior MI lead to AV block, RV infarction lead to hypotension. Troponin rise alone is not equal to MI. Please remember. Suppose if somebody is having renal failure, even if MI is not there also, troponin can rise. Understand? Somebody has diabetes, chronic kidney disease. In them, the rise of the troponin need not be always due to MI. It can also be due to renal failure patients. And for reinfarction, what is the best investigation? CKMB is what you need to remember. Then after MI, how do you want to manage the patient? The patient lost the myocardium. He is unable to pump the blood. He will suffer from hypotension. So, what is the way you can judge how severely, badly the myocardium is affected? You do 2D echo and calculate ejection fraction. What is ejection fraction, doctor? Heart receives the blood. Heart pumps the blood. So the amount pumped by the amount received. So normally 65% of the received blood is pumped. But the moment it goes to less than 35%, heart failed as a pump. So that is an indication for ICD. What is intracardiac defibrillator? Because whenever the heart suffers severe infarction with a very low EF, the dilated heart any moment will throw arrhythmias. So you should immediately sense the arrhythmia and defibrillate it. Otherwise, patient will go into sudden cardiac death whenever their EF is less than 35%. So ICD is indicated whenever the EF is less than 35% after 40 days. Similarly, we have aldosterone antagonists. Agreed? So spironolactone, excellent. Eplerenone, right? All these antagonists, they decrease the mortality if you give. Why? Once the LV dysfunction is there, what will happen? Cardiac output decreases. Right? Decreased cardiac output decreases the renal blood flow. Decreased renal blood flow will decrease the pressure in the afferent arteriole. Decreased afferent arteriolar pressure will decrease the GFR. Decreased GFR will stimulate the juxtaglomerular apparatus to release renin. Renin causes angiotensin 1 to become 2. That in turn will go and stimulate aldosterone. Aldosterone will come to collecting duct and lead to retention of sodium. And retained sodium lead to retained water. And the person is in a state of edema and waterlogged state. Mala cheptara mottham sequence. LV infarction, decreased cardiac output, decreased renal plasma flow, decreased afferent arterial pressure, decreased GFR, decreased tubular flow, stimulates juxtaglomerular apparatus to release the renin. Increased renin increases the angiotensin 2. Increased angiotensin 2 will go and stimulate the adrenal to release the aldosterone, and aldosterone will lead to retention of the sodium, retention of the water, and worsening of the edema. You have to break that cycle somewhere. So you give aldosterone antagonist to counter that increased aldosterone state in case of the LV dysfunction and MI is what you need to remember. Now, there are certain important exam favorites of the examiner. Looking at the ECG, you can know where is the infarction. So here you have a lead called AVR. If there is a ST elevation in AVR and throughout the ECG, if there is a diffuse ST depression, then that indicates the occlusion is in the left main coronary artery is what you need to basically remember. Manu, just check with Mary and Bhagya. Someone is coming. What? Just recheck. Clear? Then, second important rule. Whenever MI is there, not in anterior wall, but in posterior wall, you have only anterior leads and lateral leads. You don't have leads placed in the posterior wall, right? How do you detect? You look for the reciprocal changes in the anterior leads. When posterior wall MI is there, look for the reciprocal changes in the anterior leads. So what are they? If there is an anterior wall infection, you expect ST elevation in V1 to V3, which are anterior leads. But if posterior wall infarction is there, instead of ST elevation, you get ST depression, right? So when there is a ST depression in V1 to V3, that confirms it is a posterior wall MI. So in case of MI, what is the definitive indicator that there is an MI and you have to thrombolize? You have to look in ECG for compulsory ST elevation. The presence of ST elevation is an indication for thrombolysis. Then how about non-ST elevation MI? Suppose if it is subendocardial MI, ST elevation may not be there. There you need to look at the cardiac enzymes. Elevation of the troponin is an indication, even if ST is not elevated, that the possibility of MI is there. Understand? So there are few scenarios where there can be a problem. What is that scenario? It's called left bundle branch block. What is the meaning of left bundle branch block? So if you look at the heart, SA node in the right atrium will send signals to AV node. AV node will become left and right bundles of Purkinje, which in turn will go and supply the myocardium. So if this left bundle is blocked, right? Left bundle is blocked, all their ST will alter. You can't interpret. Even before getting heart attack, only patient will have ST segment elevation. Without MI, if the LBBB is there. Agree? So, if the LBBB is there and such a patient develops chest pain, how will you identify that there is an MI? That's called Garbosa criteria. So, what do you mean by Garbosa criteria? When will you use that? Whenever somebody has got a chest pain and earlier ECG already had LBBB, you can't interpret the ST segment elevation. In that scenario, you have to use the Garbosa. Okay. So now, what are the Garbuza criteria? Right? What are the Garbuza criteria? Concordant ST elevation more than 1 mm in any lead. What is the meaning of concordant ST elevation? If the ST elevation is up, T wave is also up. It is not inverted. That's called concordance. But if ST elevation is there and T is inverted, that is called discordant. So concordant ST elevation more than 1 mm. It should be more than 1 mm. See, in the ECG, you have large block, small blocks. Each small block, height is 1 mm, width is 1 mm. ST elevation more than 1 mm in any lead, and there is a concordance. That means T is not inverted, ST is elevated. Clear? Then concordant ST depression. ST segment, if it is depressed, right, more than 1 mm, you can see ST depression more than 1 mm. At the same time, T wave should not be inverted, right? That's called concordant ST depression. More than 1 mm in lead V1 to V3, which are anterior leads. Second criteria. Third, there is an ST elevation. ST elevation. And there is a S wave, right? If the ST elevation divided by the S wave depth is more than 25%, that is called Garbuza criteria 3. Understand? So remember, in medicine, there are some things good to know. There are some things must to know. And a great student is the one who realizes what is must to know. Must to know means, even if I scratch, you should rattle it out. Like why we use aldosterone antagonists in MI. A Garbuza criteria and all are good to know. Suppose in reading room you found a guy who is saying, I'm reading Harrison. Oh, అట్లయితే గార్బోజా క్రైటీరియా చెప్పారు చూద్దాం. నీ ముఖానికి గార్బోజా క్రైటీరియా తెలియదు, హారిజన్ అవుతున్నాడు. చల్. What is the purpose of going to reading room? To depress others. So you should have ammunition of questions. Half the time we used to spend in reading room only to depress others. నీ ముఖానికి కష్టం రా, ఈ నోట్స్ చదువుకోండి. They're all cardiologists now. So what I'm telling you is Garbuza criteria. Where will you use that? Whenever there is a LBBB and you can't interpret the ST segment changes, you need to look for the concordance and be sure there is an MI. Okay. Now, whenever there is a sepsis, that also will compromise the myocardial flow, coronary flow. There also troponin will increase. That's called the type 2 MI. It's called type 2 MI in sepsis. Clear, doctor? Now that completes our MI. So tomorrow, every MBBS final year exam, you go, there is a question on MI. Every NEETPG entrance you go, there is a question on MI. You should be very sure. Clear, doctor? Now, let's continue the discussion. Very good. Good to see 7 online classmates. Yeah. Okay. Now, hypertension is the second topic. How is the petrol? Petrol is there. Full tanker. Energy. Huh. Let me know when you need refill of petrol. Otherwise, I'm capable of talking 16 hours or 18 hours a day. Huh? Manu, this window become too narrow, I think. కొంచెం వెనక్కి try చేయి. This a little back. Try. Now, how do you define hypertension? The Granima asks you a question. How do you define hypertension? This looks a little better. More window. Blood pressure more than 140 systolic by diastolic 90 was traditional, but American Cardiology Association decided in the recent guidelines that it is more than 130 by 80. What is the hypertensive urgency, emergency? You need to be sure. Any BP more than 180 by 120 without organ damage, you call urgency. What is organ damage? Renal dysfunction or papilledema or any heart attack. Without any organ damage, only more than 180 by 120 is urgency. BP elevation with acute target organ damage is called as the emergency. Then in elderly people, you will find diastolic normal but systolic only elevated. That's called isolated systolic hypertension in the elderly is what you need to remember. Now, what is an essential hypertension? The moment you cross 40, you became associate professor of medicine. You became a senior consultant. Wow. That's great, glamorous. Your child is going to 9th class, 10th class, 8th class. He's not studying. He don't know what is biology. He hates it. We have to accept. In our days, हम बहुत मेहनत करके बाजपल्ली से पतपराव नगर आके पढ़ाई किया. Come on, cut the crap, daddy. It's ChatGPT. Your son will be saying, right? You don't need to be smart, daddy. You need to be a good Instagram influencer to earn money, not necessarily a doctor, he will say. So, what will you do? Your arteries become stiff, peripheral resistance increases, and that leads to essential hypertension. So, any hypertension that comes between 40 to 60 is called essential hypertension. But any hypertension starting at 20, 30, 35, 40, that is called, you need to evaluate for secondary hypertension. Agree? Now, it is the renin, angiotensin, aldosterone system activation that lead to vasoconstriction, sodium retention, water retention that increases the BP. Pathophysiology. Similarly, all our blood vessel endothelium is under a constant stress because of the pizzas, burgers, smoke, pollution, blah, blah, blah. So endothelial dysfunction with the decreased nitrous oxide. Nitrous oxide is a vasodilator. Any decrease of that will increase the vascular tone. Similarly, whenever somebody has a chronic kidney disease by hypertension, normally kidney is responsible for draining the fluid from the body. Then there is a lot of fluid retention, volume overload, right? And there is renin-angiotensin activation. High angiotensin lead to sympathetic activation. That lead to hypertension, pathophysiology in CKD. Then you find a fat, obese man who is having continuous snoring. That's called obstructive sleep apnea, where the uvula will block the respiratory path. So whenever there is an obstructive sleep apnea with hypertension, there is an intermittent hypoxia that lead to sympathetic overactivity that lead to development of hypertension. Now, there are some important clinical case minutes you need to know about hypertension. A young hypertensive has got hypokalemia. What is the underlying cause? Young patient, MD second year, he is doing general medicine. He found to have hypertension. Every hypertensive get electrolytes done. He has hypokalemia. What is the underlying cause? Adrenal adenoma. Excessively produce the aldosterone. That's called Conn's syndrome, CONNS. In Conn's syndrome, when the aldosterone level is increased, aldosterone lead to retention of the sodium and loss of K plus into urine, leading to development of hypotension. And Conn's syndrome leads to retained sodium lead to vasoconstriction, fluid retention, leading to hypertension. So, any young hypertensive who has hypokalemia is equal to primary aldosteronism is what you need to remember. Anybody who has got a paroxysmal headache with sweating, with palpitations, think of pheochromocytoma. Anybody who is having abdominal breath and resistant hypertension. What is the meaning of resistant hypertension? In spite of using 3 antihypertensives, maximum dose, plus a diuretic. If the BP is not controlling, then you call resistant hypertension. You think of renal artery stenosis. Once more, what is the funda in renal artery stenosis? Any renal artery stenosis will decrease the renal afferent arteriolar pressure, decrease the GFR, stimulates renin-angiotensin. That lead to hypertension. Are we clear on this? Okay. Then similarly, somebody has an upper limb hypertension but a weak femoral pulse. That is because of the constriction of the aorta, coarctation of aorta. So that the blood flow to the lower limbs is diminished. Then any elderly with an isolated systolic hypertension, you need to think of the vascular stiffness is what you need to basically remember. I'm so happy to see 13 online. We are always happy to see students before our eyes. So gone are the days, this dirty COVID made people habituate to online for everything, including marrying, romance, and producing children also. Right? So we are in a very bad era. So please come. We have a beautiful Padmarao Nagar Center. We'll give air condition, give you some nice coffee shortly. We'll put up a coffee machine, right? And if you are there, I can teach before my eyes in live class. I can teach 12 hours, 14 hours also, which is bad. I will never do that. Don't be scared. Online, very difficult to maintain the petrol, right? So, but anyway, thanks for coming online. Now, doctor, abdominal breath, resistant hypertension, renal artery stenosis. Then these are the important caveats you need to know. Now, what is the first line drug of choice is the favorite question. 4 drugs, doctor. Thiazide. We give hydrochlorothiazide. Have you heard? Telma H. Telma H is the brand. H is hydrochlorothiazide. So thiazides. ACE inhibitors. Nowadays we are not giving that much. Enalapril. Then ARBs, telmisartan. And calcium channel blockers like cilindipine, amlodipine, nicardipine. They are first line. Then ACE inhibitors, how do? They decrease the conversion of angiotensin 1 into 2. So decreased angiotensin 2 will cause vasodilatation. Why calcium channel blockers? They relax the smooth muscle of the blood vessel by blocking the calcium. That lead to arterial dilatation, decreased SVR, systemic vascular resistance, and decreasing afterload on the heart. Then the beta blockers decrease the heart rate and decrease the cardiac output is what you have to basically remember. Now, some important classical adverse effects. ACE inhibitors are known to lead to cough. Why? ACE inhibitor is inhibiting angiotensin converting enzyme, which converts angiotensin 1 into 2. Same converting enzyme is required to break the bradykinin. If you block the converting enzyme, you are also preventing bradykinin being metabolized. So increased bradykinin lead to bronchoconstriction leading to dry cough. That problem is not there with ARBs, angiotensin receptor blockers. ACE inhibitors can lead to angioedema. If at all there is a drug absolutely contraindicated in pregnancy because of teratogenic effects, ACE inhibitors and ARBs are strictly contraindicated. Then thiazide diuretics whenever you give. Remember, you have thiazide diuretic, loop diuretic. Rule. Don't forget this dictum. Say after me. Loop diuretics lose calcium. Loop diuretics lose calcium. Thiazide diuretics retain calcium. Clear? Both loop and thiazide diuretics lose potassium. Hypokalemia is common, but loop diuretics lead to hypocalcemia. Thiazide diuretics retain calcium and lead to hypercalcemia is what you have to basically remember, doctor. Right? So good. Dr. Williams say, I was a student of you, now doing my senior residency after MD. Still watching and can't forget you, sir. Good. So we all live for such compliments, doctor. Teachers are poor emotional creatures, right? Now, spironolactone, it is an aldosterone antagonist. Aldosterone lead to retention of sodium, loss of potassium into urine and hypokalemia. And its antagonist will cause hyperkalemia. And also, spironolactone lead to, it antagonizes the androgen. That's the reason estrogen become dominant and that can lead to breast in males, gynecomastia. Hyperkalemia, gynecomastia, spironolactone. Then the calcium channel blockers, they typically lead to fetal edema. A lot of times grandma will tell, तूने कुछ दवा दिया और मेरा पाँव में सूजन आ गया. Calcium channel blocker. Calcium channel blocker also lead to gingival hyperplasia. So remember these side effects. Now you need to know certain important combinations. Be careful to, while you are combining ACE inhibitors or ARBs with NSAIDs. Why will you give NSAID? Grandma has hypertension. Grandma also has arthritis. So whenever arthritis is there, you try to give NSAID. NSAID will lead to development of hyperkalemia. So the combination will cause hyperkalemia and the grandma will die due to hyperkalemia. So be careful. Then NSAIDs, be careful to give because NSAIDs will inhibit prostaglandin, decrease prostaglandin, right? What is the effect of prostaglandin on juxtaglomerular apparatus, doctor? Any decreased prostaglandin stimulates renin, angiotensin, aldosterone and lead to sodium retention. That's the reason NSAIDs increased BP by decreasing the prostaglandins, which will lead to the retention of the sodium and vasoconstriction and hypertension. Oral contraceptive pills will increase the BP because they increase the angiotensinogen and they stimulate the renin-angiotensin system. Then, whenever you give beta blockers, especially in those who have type 1 diabetes, They are taking insulin. Insulin lead to hypoglycemia. Hypoglycemia stimulates sympathetic system. But giving beta blocker will block that sympathetic activation. अगर शुगर कम हो गए तो हाइपर हो जाते, पूरा स्वेटिंगा निकलते, मगर वो स्वेटिंगा नहीं निकालते कब? अगर बीटा ब्लॉकर ले रहे तो। अगर शुगर गिर गया, सिंपैथेटिक एक्टिवेशन हो गया, तो पूरा धड़कन शुरू हो जाता दिल में, palpitations, sympathetic activation. But if you are giving beta blocker, that won't happen. That's the reason beta blockers can mask the hypoglycemia and patient will go into hypoglycemia and die. That's the reason be careful to give, especially those who are taking insulin, the beta blockers, because beta blockers can lead to hypoglycemic unawareness is what you need to remember. Right? So one of the important antihypertensive is clonidine. Have you heard clonidine? Clonidine is, see, all our problem in MBBS is physiology, we don't read the receptors, sympathetic receptors. I'll quickly tell you. Alpha 1, alpha 2, beta 1, beta 2, 4 receptors, sympathetic receptors. Alpha 1 lead to vasoconstriction, and that will lead to BP increase. Beta 1 is present in the heart, one girl, one heart, right? Beta 1, and that will increase the heart rate, and it will also increase the cardiac output. So any beta 1 stimulation lead to hypertension. Beta 1 blocking lead to normalization of the hypertension. Clear? Where is beta 2? God gave 2 lungs. It is there in the bronchi. Beta 2 stimulation lead to bronchodilation, not constriction, bronchodilation. That's the reason we give beta 2 agonists, salbutamol, salmeterol. All these are beta 2 agonists in treating the asthma by leading to bronchodilation is what you need to basically remember. Okay, then most important is alpha 2. Where is alpha 2? It is there in the brainstem. Any stimulation of this alpha 2 will decrease the release of the norepinephrine, and that lead to vasodilatation. Tell me, what does alpha 2 agonists or antagonists? Agonists. Alpha 2 agonism will cause the stimulation of alpha 2 receptor that will decrease the release of the norepinephrine, and that lead to vasodilatation by decreasing the sympathetic activity. Clear? Malokasari chepkudam. Alpha 1 stimulation lead to vasoconstriction, BP high. Alpha 2 stimulation lead to decreased norepinephrine release and decreased sympathetic activity, vasodilatation, and antihypertensive. Beta 1 stimulation lead to hypertension. Beta 1 blocking lead to antihypertensive. Beta 2 is there in the lungs. Stimulation lead to bronchodilation. Suppose you use a non-selective beta blocker like propranolol, right? It will block beta 1, so it will help the person to the BP to normalize, but it will also block beta 2 and lead to bronchoconstriction, worsen the asthma. That's the reason we use metoprolol, atenolol. They're all what? Selective only to block the beta 1 without affecting the beta 2 is what you need to basically remember. So this clonidine is available as a 1 rupee tablet, cheapest tablet in BP tablets. It is available as a brand called Arcamin. It is available as 100 micrograms of Arcamin. This is like a last Brahmastra on BP. First you will try with telmisartan, amlodipine, cilindipine, metoprolol. Then if it is not resolving, and then you will also add diuretic, hydrochlorothiazide. Right? Still not resolving, then you give clonidine. Especially, clonidine is the favorite drug for the nephrologists. Their kidneys, which are failed, they won't listen to the word of simple atenolol or metoprolol or telmisartan. You have to use Brahmastra, which is clonidine, Arcamin tablet. You have to use 3 times, 100 micrograms, 3 twice. But if somebody is taking Arcamin regularly, suddenly did not take, that lead to withdrawal, clonidine withdrawal. Suddenly this inhibition of the norepinephrine release gone, and that lead to increase in sympathetic activity and lead to rebound hypertension is what we need to remember. Now let us talk secondary hypertension, the high yield things, right? Yes. The most common cause of the secondary hypertension is renal parenchymal disease. Conn syndrome, which is primary aldosteronism, will lead to increased aldosterone and lead to development of sodium retention, water retention, and hypertension. What do you mean by secondary hyperaldosteronism? Primary ante adrenal adenoma. What is secondary? Whenever you are dehydrated or blood loss is there, then what will happen? Or you have vomitings, diarrhea. When you are dehydrated, decreased blood flow to the kidney, stimulates renin-angiotensin, leading to increased renin, increased angiotensin, increased aldosterone. Such a hyperaldosteronism due to the dehydration and vomiting is called secondary hyperaldosteronism. What is it called? Secondary. Etlunte secondary vomiting ayindi, dehydration ayindu, decreased renal blood flow. Juxtaglomerular apparatus is made to release renin, angiotensin, aldosterone. That is called secondary. That means you have high renin leading to high aldosterone is secondary. What is primary? You have adrenal adenoma. It don't need renin to come and tell it. Without telling of renin only, it starts producing aldosterone. That is primary. How will you recognize? High aldosterone with a low renin. In fact, renin will be suppressed. Got me? High aldosterone, low renin is equivalent to primary hyperaldosteronism. High aldosterone, high renin is equal to secondary. Don't forget. Similarly, pheochromocytoma. So any young age, resistant hypertension, sudden in onset, suspect secondary. So you can see here. What do you see here, doctor? Above the kidney. Can you appreciate the adenoma of the adrenal, which is overproducing the aldosterone, which is called Conn syndrome. How do you investigate? How do you investigate? We take aldosterone-renin ratio. Agree? To screen aldosteronism. You will pass a catheter into renal vein. Akkada you will calculate the renin value, aldosterone value. Aldosterone to renin ratio. What will happen to aldosterone renin ratio in case of primary versus secondary? Aldosterone increases, renin increases. What is the situation called? Renin increases. Secondary. Aldosterone increase, but renin decrease. So ratio will increase. When the denominator decreases, ratio increases. So the physics anta. So before coming morning, I was teaching thermodynamics chapter to my second son and his friends in physics, solving the problems. Right? Always physics used to fascinate me like general medicine. Logic oriented, computation oriented. Unfortunately, the present kids are not habituated to calculate the money and going to the supermarket. They're all using Paytm, Karo. So their counting skills are gone. Right? So you do Doppler CTA, Doppler and CT angiogram, MR angiogram in order to identify renal artery stenosis. And also you do microalbuminuria in the urine to know whether hypertension led to the renal dysfunction and early organ damage. You do metanephrines in the urine to identify the pheochromocytoma. Now what is hypertensive emergency? There is a papilledema, right? Along with BP more than 180 by 90. So when end organ damage is there along with the hypertension, you call hypertensive emergency. That's the reason always carry the fundoscope. Try to check through the fundus. If papilledema is there tomorrow as an intern, don't miss that habit. So you have to rapidly reduce the BP to 10 to 25% in the first hour. What is 20% of 180? 36. So you should bring 180 to 150 systolic in the first 1 hour. So what is the Brahmastra you will be using to treat? We use the IV drugs like labetalol, nitroprusside, and nicardipine in order to treat a hypertensive emergency is what you need to remember. All right, now? Now, whenever there is an accelerated hypertension and a hypertensive emergency, patient is having aortic dissection, how do you treat? So please remember, aorta undi kada? It has got a intima tunica media. Between the two, the blood is seeping in aortic dissection. Right? So when aortic dissection is there, most important thing is to control. They will present. Why does aortic dissection occur? It is a consequence of your hypertension. So you need to control the hypertension by giving a beta blocker. Is the rule in aortic dissection. So that it will decrease the shearing stress, which is ripping off the wall of the aorta, is what you need to remember. Clear, doctor? Then, whenever you are giving nitroprusside, remember, it can lead to cyanide toxicity. So these are a few caveats about hypertensive emergency. What are the drugs that you use, doctor? 3 drugs. Labetalol. What is the specialty of labetalol? Labetalol is both a alpha and beta blocker. Is labetalol. Clear? Nitroprusside, nicardipine. These are all the drugs in hypertensive emergency. Now there are some special scenarios that we need to know. A pregnant woman came with hypertension. What is the safest drug in pregnancy, doctor? Labetalol. Then you can give methyl dopa, safe in pregnancy. Nifedipine, safe in pregnancy. 3 drugs, safe in pregnancy. Strictly contraindicated, ACE inhibitors and ARBs are strictly contraindicated. Whenever you are having a patient of CKD, हम इस देश के वासी है जिस देश में टीबी बहती है, शुगर रहती है, राइट? Every fourth patient is sugar. We are an agrarian society. We eat rice, idli, dosha, sambar, morning to evening, right? So that lead to development of diabetes, leading to chronic kidney disease. So chronic kidney disease, there is hypertension, then you need to treat with ACE inhibitors and ARBs that will decrease the proteinuria, is what you need to remember. Then GFR, always there is a lab investigation called eGFR. Any GFR, when it goes less than 30, then you need to use loop diuretics, not the thiazide diuretics, rule of the game. Loop diuretics and torsemide, Ditor. You heard of the drug? Ditor. Ditor is a common tablet we use as a diuretic. That contains torsemide. Torsemide is a loop diuretic like furosemide. Furosemide ka anna is torsemide. Okay, 5 mg, 10 mg we use. So whenever GFR is less than 30, you have to use loop diuretics, but not the thiazides. Is a very important rule. Similarly, any person who has got a HOCM with hypertension, avoid vasodilators and use beta blockers. Another big story is there for this about HOCM. I'll come down the line. So you will remember the special scenarios? Very good. Now, what is the resistant hypertension? See, as a physician, what is the important rule in OP? Patient comes, you checked BP. 5 minutes you spent and asked him, get out. That is wrong. You have to sit half an hour at least to explain the patient. What is BP? Why he got hypertension? What drugs he need to use? How are they working? What is the importance of self-monitoring of blood pressure? You have to ask him to buy one automatic BP machine. Keep a book. Tell his wife. Wife will be happy to check the BP. If it is 20 units more, she will threaten the husband that if you shout anymore, your BP will be high, you will get stroke. Right? And ask the wife to send you on the WhatsApp 3 times BP values. Okay? That is the most important thing you should remember in life. Okay? So, what is the definition of resistant hypertension? You use telmisartan. What is the maximum dose of telmisartan? 80 milligrams. Hydrochlorothiazide, maximum is 25 milligrams. You have used a beta blocker. Beta blocker maximum dose is about metoprolol 50 milligrams. We start at 25 and we'll go up to 50 milligrams in some people up to 100 milligrams. Right? Then we use amlodipine or cilindipine, maximum dose. Still BP is not controlling. That is the definition. In all such cases, what is that wonder drug? If you add, the BP will come to control. You should add spironolactone. What is the mechanism of spironolactone? It is a aldosterone antagonist, right? Because the entire pathophysiology of the hypertension lies in activation of renin-angiotensin and high aldosterone levels is the underlying problem in the entire hypertension. So what is the cause for resistant hypertension? Please remember, you write medicines, but patients don't take medicines. You deliver a class, but student does not do revision. Who's wrong? Students should do revision. Teacher's job is not to teach, but to inspire you to revise. Correct? Then, he may be a very obese person, nighttime snoring and obstructive sleep apnea is there. That lead to resistant hypertension. Any number of BP tablets you give will not help. You have to put a nighttime BiPAP machine, not to push the air in. Unless you treat that obstructive sleep apnea, the BP doesn't control. So you need to look for all these underlying causes. Right, doctor? So ultimately, what is the target? The target BP is less than 130 by 80. And what is the most effective lifestyle method? Lose the weight, lose the BP. And how much salt you should restrict to? Less than 2.3 gram per day. When we were postgraduates, we used to have a very affectionate professor. He used to make us weigh the salt, make it how 2.3 grams looks like, and then show to the patient, this is the amount of salt in your entire day diet of your husband. Right? So the difference between a great doctor and a useless doctor is very little, not knowledge. It is your dedication to make patient understand the problem and get influenced to stick to the recommendations. That is most important, doctor. Then DASH diet. What is the DASH diet? Typically grains, lean protein, legumes, fresh fruits. So fruits plus low fat will decrease the BP, which is called DASH diet. And next, you have to tell Daru wala, Daru kam karo. Right? Alcohol reduction is the best way to bring down the hypertension. If MLA Edu Kondalu came to you as a patient, even if you write top cardiologist and write 10 drugs, evening hote hi wo whiskey bottle open kar diya. What is the use of all your drugs? No use. Alcohol reduction. Okay, doctor? So, few important points you need to know. OSA, obstructive sleep apnea, lead to hypertension because of the sympathetic activation is what you need to remember. Now, there are certain important triggers that you need to keep in mind. Any hypertensive patient suddenly in the night develop shortness of breath. That's called flash pulmonary edema. Regular hypertension does not lead to pulmonary edema. There is a pulmonary edema, something fishy. What is that fishy? Whenever any patient has a bilateral renal artery stenosis, that typically lead to flash pulmonary edema is what you need to remember. Any resistant hypertension with hypokalemia, think about primary hyperaldosteronism. Any hypertension with episodic symptoms, think of fear. Right? Then what is the goal of the BP in aortic dissection patient? You need to bring down the systolic BP to 100 to 120, right? Is the goal. Plus, you need to control the heart rate by giving beta blockers. Then only that shear stress on the aortic dissection will not come to control. Okay, doc? That is all about our second topic. You have energy to swim through 31 topics? Yes. Entire cardiology is done. Okay, we'll take a 5-minute break and rejoin. So let us take the journey to the next level, doctor. Infective endocarditis is the third most high-yield topic. This is more easier because there is not much of logic, unlike our earlier topics. The most common cause, whether it is acute infective endocarditis or IV drug users infective endocarditis, it is a Staph aureus is what you need to remember. So in few people who are having valvular heart disease, if they undergo a dental procedure, the organisms will go and cause infective endocarditis. In that scenario, it is called subacute infective endocarditis, which is due to viridans streptococci. Similarly, whenever you do any genitourinary procedures, then enterococcus can lead to development of infective endocarditis. And any person who is showing Galeoliticus, Streptococcus galeoliticus, bacteremia, it is a clue to say that the bacteremia is often because of the colon carcinoma. That's the reason he need to undergo colon carcinoma screening. When colon carcinoma is there is a breach of the barrier and all the colonic organism, Streptococcus galeoliticus, will go to the valves in the heart. Then there are HESEC group of organisms. What are HESEC group? H for Haemophilus, A for Acinetobacter, E for Eikenella corrodens, and K is Kinganella kingae. HESEC. Where do you expect them? Normally you do culture, blood culture, to detect the staphylococcus and all. But if it is culture negative infective endocarditis, because these organisms don't grow in those culture media used for Streptococcus staphylococcus. That's the reason it is called culture negative infective endocarditis is due to the HESEC group of organisms is what you need to basically remember. And they're all ceftriaxone sensitive. Whenever history of exposure to the farmer, culture negative endocarditis is there. Think of Coxiella perniciae, Q fever. Any exposure to cat in a homeless individual, think of Bartonella hensley, which is also culture negative infective endocarditis. Any immunocompromised patient or an IV drug abuser, fungal infective endocarditis is common, but they are all very big sized. That's the reason only antifungal therapy doesn't suffice. You need to give surgery, which is mandated. So whenever any IV drug abuser is there and he has got nodules in the lung, so normally most of the infective endocarditis are all on the left heart. But IV drug abuser, it will go through SVC organisms when he is injecting drugs and goes to right side, involves tricuspid valve. Any tricuspid infective endocarditis, it is more common in IV drug abuser. And also from the right atrium, it goes to right ventricle, it will go to lung and it will cause nodules in the lung. Then any fever, murmur plus emboli, it is a classic triad of infective endocarditis. The most consistent feature of clinical symptom of every IE is fever. There is no IE without fever. So whenever infective endocarditis involves the left side of the heart, left side heart pumps into aorta, into cerebral vessels. That's the reason there will be cerebral emboli, which will be there. Any person whose blood has grown Staph aureus bacteremia, invariably you need to rule out infective endocarditis. And any bacteremic individual, whenever there is any new murmur, you need to suspect infective endocarditis immediately. Now, what are the various valves? The most common valve which is involved in the IV drug abuser is tricuspid valve, right? And if you suppose somebody had mitral stenosis, aortic stenosis in the childhood due to rheumatic fever, when they become adults, you will do valve replacement and put a prosthetic valve. So prosthetic valve infective endocarditis. Early stage, the most common organism is staph epidermidis. That means valve lagane ke baad, first 6 weeks, if there is infective endocarditis, then it is staph epidermidis. Late prosthetic infective endocarditis is because of viridans and staph aureus is what you need to remember. So how do you diagnose infective endocarditis? So once more, good to see 10 online classmates. Remember, every Sunday we have medicine mela and totally 118 topics. We planned 4 Sundays. It may take another 3-4 Sundays, no problem. But we will finish all. The one who finished medicine is a king. And if time is there, we will take surgery, then gynops, ortho, pediatrics, ENT and ophthalm, all the final subjects. Every subject there will be small subjects like ENT, ophthalm, ortho, ped. 50 topics. Sure shot, both in final year and also for entrance. Surgery and gynops, 100 topics. Okay, right. Now, Duke's criteria. The blood culture being positive along with the 2D echo showing the vegetation is a part of Duke criteria. And it is more than 3 blood cultures without giving antibiotics. Before antibiotics is the essential thing. Then how do you find the valvular vegetation? One is you can do transthoracic echo, which is regular echo. Second, if it is there in the mitral valve, it is in the posterior chamber, left atrioventricular. There you have to put endoscope. So through the esophagus. Transesophageal echo is required if it is small vegetations in the posterior chambers. So this esophageal is more sensitive. Even a small one it will pick. Then TT is the gold standard for imaging. And especially whenever prosthetic valve or a abscess due to the infective endocarditis is suspected, TE is preferred. Transesophageal 2D echo is the one which is being preferred. Right? Now, there are some peripheral signs in infective endocarditis. Osler's nodes are the painful immune-mediated lesions. Janeway lesions are painless septic emboli. Roth spots you see in the retina because the hemorrhage and immune vasculitis. And splinter hemorrhages are the microemboli in the nail bed. So these are the important peripheral signs of infective endocarditis. Don't forget. Mainly, Osler nodes are painful. How will you remember? Painful cervical os. Os is os. Obviously, the other way is painless. Now, what are the complications? Septic pulmonary emboli in right-sided infective endocarditis, CNS emboli, left-sided. Then there can be, the blood vessel wall can become weak and can lead to myocardial aneurysm that can rupture. Then, because of the heavy fungal walls hanging on the mitral valve, it can lead to acute MR, to the papillary muscle dysfunction. And any perivalvular abscess caused by the infective endocarditis can lead to AV block, heart block. That is a surgical emergency, is what you need to remember. Then how do you manage? Empiric therapy, vanco plus ceftriaxone, MRSA, vanco or daptomycin, very important. Enterococcus is a special scenario. You need to combine one aminoglycoside gentamicin with ampicillin. Ampi-genta need to be compulsorily combined if it is enterococcus. Please don't forget. Favorite MCQ of exam. Then for HESEC group of organisms, it is ceftriaxone, 4 to 6 weeks. So total duration is not 2 days, 5 days or 10 days. 4 to 6 weeks intravenous antibiotics are needed in order to treat the infective endocarditis. When will you do surgery? Whenever infective endocarditis lead to regurgitant lesions of the valves and that is leading to the heart failure, time to do the surgery. Any bacteremia persisting more than 72 hours, surgery. If there is any abscess leading to AV block, surgery. Any large fungal vegetation, embolization, you need to do surgery. Just not the medical therapy in infective endocarditis. Now, what are the associations? IE patient developed hematuria. Think about immune complex glomerulonephritis. IE patient with splenic infarct with abdominal pain, systemic embolization. IE patient with anemia. Infective endocarditis is a chronic condition like osteomyelitis, TB, infective endocarditis. There, it is the normocytic anemia of the chronic disease. And these are the important things to remember. So how do you evaluate? To know the emboli and abscess, you can see here, this is a brain abscess which is formed by the embolization. Then serial blood cultures you need to do to check whether the bacteremia cleared or not. ESR and C-reactive protein you can use to monitor. Right? Now, very important is, whenever you put a prosthetic valve, infective endocarditis there is typically from biofilm. Antibiotics cannot penetrate to kill them. That's the reason resistant infective endocarditis can occur because the biofilm forming organisms that prevent the antibiotic penetration is called prosthetic valve. Infective endocarditis is what you need to remember. So, infective endocarditis with stroke, early surgery possible. Infective endocarditis with stroke with hemorrhage. Once more, you have to delay surgery. Infective endocarditis with a catheter infection, remove the catheter and give antibiotics. Whenever splenic abscess is there, drain it and give antibiotics. Any fungal infection is there, you have to do surgery, not just the antifungals. That is all about infective endocarditis is what we need to remember. Now, doctor, heart sounds and murmurs. Favorite question of the examiner. Labbu, dabbu. So during preparation to MBBS entrance exam, we all dream apron, stethoscope, and all. After joining, we don't wear it. And professor has to cry, please bring your stethoscope, right? Okay. Stethoscope has a bell diaphragm. Why? Two things. Because Littman is very attractive, L-shaped, to win the heart of the girl. No, sir. What's the purpose of diaphragm? If you look at the heart sounds, they can be of high amplitude or they can be of low amplitude. High amplitude will have amplitude is inversely proportional to 1 by frequency. So high amplitude will have low frequency, low amplitude will have high frequency. So whenever high amplitude is there, you have to use the bell. Low amplitude, high frequency, you have to use the diaphragm. Are you clear? Diaphragm for low amplitude, high frequency. Bell for high amplitude, low frequency. Clear? Now, S1, S2, they both are low amplitude, high frequency. That's the reason we use the bell. Sorry, we use the diaphragm. So, S1, best head is the apex, and it is the closure of the AV valve. What is AV valve? Between atrium and ventricle, mitral and tricuspid. When this closes, you listen the lub, which is S1. Clear? Now, my question to you is, the closure of the AV valve, when will it occur? From the atria, ventricle got filled. Ventricle diastole, it is called. End of the diastole, when the ventricle is fully pregnant with the blood, then the AV valve will close. So the closure of the AV valve marks the end of diastole or systole? The closure of the AV valve is the end of, once more, let's go slow. From atria into the ventricle, the blood has flown and ventricle has undergone diastole. At the end of the ventricular diastole, the AV valve closed after the diastole is over. So the closure of the AV valve is an indicator of end of diastole. And the beginning of, after the diastole is over, what will ventricle will do? Contract. And systole occur. So the end of the diastole and the beginning of the systole is equivalent to closure of AV valve, which is equivalent to S1. S1 marks the end of diastole and beginning of systole. After S1, everything is systole. Before S1, everything is diastole. Once more. Diastole, the blood moved into the ventricle. S1. Once diastole is over, S1. Then systole, start. The close eye. This will open and blood will move into aorta. End of the systole. After all blood is ejected into the aorta, aortic valve and pulmonic valve will close. So you get the second function. So diastole, lub, systole, dub. Come on. Diastole, lub, systole, dub. This is the sequence you need to do. After lub, systole. After dub, diastole. After diastole, S1. After S1, systole. End of the systole, S2. Right? So, diastole, S1, systole, S2. Diastole, S1, it goes on. So, if you look at the S2, it is the closure of aortic and pulmonic valve. Between the left ventricle and aorta, pressure is how much? 120 systolic pressure. Whereas from right ventricle and the pulmonary artery, it is only 10. 10 to 15 is the systolic pressure in pulmonary artery. 120 is the systolic pressure in aorta. That's the reason, will aortic valve close first or pulmonic valve close first? Here the pressure difference between the two is smaller. Whereas here the pressure difference is higher. This is 120. So the moment this got filled, it will kick the valve. So aortic valve closes before the pulmonic valve by a split period of time. That is called physiological split. Got me? रामू और सोमू दोनों भाई हैं. रामू का दुकान जल्दी बंद करके घर जाएगा, सोमू को थोड़ा टाइम लगेगा. इनको बिजनेस भी नहीं है और डिले भी है. इनको बिजनेस बहुत ज्यादा है, ऑलरेडी रकम आ गया, जल्दी दुकान बंद करके जाएगा घर. So aortic valve precedes the pulmonic valve when it comes to closure. When will P2 become loud? Between A to P2, P2 will become loud whenever the pressure in the pulmonary artery is high, which is called pulmonary hypertension. Okay, so this pulmonary hypertension, whenever it is high, it will kick the pulmonic valve to close and pulmonary P2 become loud. It becomes so loud that in the pulmonic area, where is the pulmonic area? Once more. Pulmonic area is the second left intercostal space. Where is it? Second left, not right. Pulmonary, right ventricle, alavokandi. Pulmonic is left second, aortic is right second. Even though aorta comes from left ventricle, aortic valve is located in aortic valve. The jet is directed towards from left to right. So right second intercostal space is aortic valve, left second intercostal space is pulmonic valve. So if there is a pulmonary hypertension, you put the stent in that person in the second left intercostal space. Thop, 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 like a cannon, you can listen the loud P2 is what you need to remember. Then what is paradoxical S2? Paradoxical S2 means normally what should happen? A2 first, P2 next. But the A2 got so much delayed, P2 will come first. Anything that delayed aortic valve closure, so delayed that in fact P2 will come first. So that happens in left bundle branch block. Happens in left. Why in left bundle branch block? Because for the A2 to close, A2, aortic valve to close, and A2 to be heard, ventricle should first depolarize, undergo systolic contraction and push the blood into aorta. At the end of that, aortic valve closes. Correct? Aortic valve, when will it close? Left ventricle should depolarize and push the blood from left ventricle into the aorta. After the end of the systole, it should close. But if there is a left bundle branch block, what will happen? The depolarization of the left ventricle is not happening. Then who will depolarize the left ventricle? The right bundle, after finishing the job of depolarizing the right side, will come and make the left ventricle to depolarize. That's the reason P2 will happen early. Later, A2 will happen. So that is the reason P2 precedes the A2. You call it as paradoxical splitting is what you need to remember. Clear? అంటే అయోటిక్ వాల్వ్ క్లోజ్ కావాలంటే క్రైటీరియా ఏంటి? ये वेंट्रिकल, लेफ्ट वेंट्रिकल में जो भी खून है, ब्लड, ये पूरा एम्प्टी होना aorta में, systolic. Then the aortic valve closes. Anything that delays this emptying will delay the closure of aortic valve. So in the left bundle branch block, depolarization start avadame delayed. Second, whenever severe aortic stenosis is there, when left ventricle is pumping the blood into the aorta, little stream is going out. So it takes longer time for emptying to happen during systole for the aortic valve to close. That's the reason what are the two causes where A2 become delayed and lead to paradoxical splitting. One is LBBB, other is severe aortic stenosis is what you need to remember. Now comes a beautiful story. Third heart sound and fourth heart sound you need to know. भैया third heart sound कब आएगा? Obviously किसके बाद आएगा? S1 के बाद और S2 के बाद? 3 comes after 2, no? So there is an S1, there is an S2, there is an S1. Between the two, there is S3 in the early part and an S4 during late part. After S2, you call diastole or systole? Diastole. So, third heart sound, fourth heart sound are diastolic sounds. Clear? What is the meaning of diastole? Kiska diastole? Ventricle. Filling of ventricle. Early part of diastole you get S3, late part of the diastole you get S4. Clear? Now, why do you get S3, S4? For that there is one story. How is ventricle filled from atria? There are 3 phases. First 1/3, second 1/3, third 1/3 of the ventricle filling. चलो भाई समझो 300 ml फिल हो रहा है वेंट्रिकल में एट्रिया से. पहला 100 ml का ये एक रीजन होता, सेकंड 100 ml का दूसरा रीजन, थर्ड 100 ml का तीसरा रीजन. So there are different reasons for first 100, second 100, third 100. Clear? Now what is the reason? Why first 1/3 of filling occur from atria to ventricle? First atria got filled from great veins. So its pressure slowly started building. That time what is ventricle doing when the atria is getting filled? Ventricle is pumping the blood into aorta. That means it is in systole. So इनका पूरा blood aorta में जा रहे. Atria is becoming pregnant with lot of blood coming from great veins. So the pressure in the atria is building and the pressure in the ventricle is losing. So at the end of the systole, aortic valve closed. S2 heard. S2 heard, aortic valve closed. So that time, atrium is fully pregnant with blood. Ventricle is completely empty. There is a pressure difference. That will open the valve, AV valve, and blood will gush. Then after 1/3 is over, almost the pressure in this and this is equal. Then second 1/3 is due to what? What did Newton's law say? Apple falls because of the gravity. Atria at higher level than ventricle. That will cause the pull of blood into ventricle. Second 1/3 be khatam. Then ventricle has 2/3 blood in it. Atria has only 1/3. That means this last 1/3 need to be pushed against higher pressure in the ventricle. How does it happen? Atria then will open up, wake up like mother-in-law. Oh, Coffee banaya kya? So it will then contract and push the blood into ventricle. So tell me, first 1/3 pressure gradient, second 1/3 gravitation, third 1/3 because of the atrial contraction. That's the reason if the atria has fibrillation, still 2/3 fills. कुछ फर्क नहीं पड़ता. So atrial fibrillation patient doesn't go into heart failure because cardiac output still 2/3 will received by the ventricle. Right? So now let us take a heart which has failed. मतलब myocardial infarction आ गया, ventricle का wall is unable to contract, so it is unable to do systole. So at the end of the systole, it is supposed to pump, let's say, about 500 ml blood. Instead of 500 ml, it only pumped 100 ml. And where did the 400 ml remain at the end of systole? In the ventricle. So now, when the diastole begins, first 1/3 of the blood is jumping into the left ventricular chamber. Where is it jumping into? Into a pool of blood. That creates a splashing sound, which is called third heart sound. Third heart sound is a sign of the left ventricular failure. Tell me, third heart sound, you are able to hear. It is a sign of failed heart. Left ventricular failed heart is a very important rule to remember. It is a sign of volume overload. Any condition where the volume over, like pregnancy, fever, beriberi, anything can cause increased preload, volume overload state that lead to early diastolic sound heard, which is called third heart sound. Clear? Then why this fourth heart sound happen? What happens during the last 1/3 of the ventricular diastole? Atria is contracting to push the blood, because during the last 1/3 already first 2/3 of the blood came into ventricle, and this last 1/3 of the blood, for it to be pushed, it has to be pushed unless atrium contracts. Okay? Assume a person has hypertension. How will be his ventricle? Ventricle is hypertrophied. It became a stiff ventricle. It is a non-elastic ventricle. It is not ready to expand into that non-compliant, non-elastic, stiff, hypertrophic ventricle in a hypertensive individual. When the atria is trying to push the blood, it has to push with the, if it is a simple balloon, you can push it. If it is like the Ottawala horn, thick balloon, difficult to push. That makes the fourth heart sound. So fourth heart sound occurred during the last 1/3 of diastole. That's the reason it is an indicator of stiff ventricle when a person is having left ventricular hypertrophy, when the ventricle is non-compact. Clear? Then what happens if there is an atrial fibrillation? Atria is not contracting. No chance of listening. S4. There is an absent S4 whenever there is atrial fibrillation. Rule number 1. For the S4 to be heard, compulsory atria must be not fibrillating. That is a rule to be remembered. One more rule, remember. If you look at the mitral stenosis, pure mitral stenosis, in mitral stenosis, the blood from the atria into ventricle, when it is moving during early diastole, less amount will move or more amount will move? Stenosis will take less amount. When will you listen S3? If there is a stagnant pool of blood with a failed ventricle, when the blood moves, it leads to S3. Whereas in MS, the amount of the blood moving itself is less. And left ventricle has no chance of failing. Why? It will fail if it has more blood coming in. That's the reason you will never hear the S3 in a pure mitral stenosis. If at all S3 is there, it is against the diagnosis of pure mitral stenosis. See, the mitral stenosis, if it is there, the ventricle is receiving very little blood for it to pump. No chance of it to fail. Right? Even if for some God forbidden reason it failed, still the amount of the blood landing in that pool of blood is very little. In either case, third heart sound is not fair. So S3 is against the diagnosis of pure mitral stenosis. If you listen the S3 in a case of MS, what is the reason? Only possibility is MS will also be associated with MR. MS is associated with MR. Combined lesion will be there in the same person. Rheumatic heart disease. If MR is there, what is happening? Whatever the blood which is coming into the left ventricle is getting regurgitated when the ventricle is undergoing systole. Because of that, the cardiac output, what happened? Decrease. And all the tissues are demanding, give me blood, give me blood. So heart rate will increase. Bhake, left ventricle one point of time will fail. And that lead to development of S3. Any failed heart. So what is the rule? Pure mitral stenosis does not lead to S3. If at all S3 is there in a case of the MS, you need to think of possibility of either MR or AR. Either of the two regurgitant lesions. Okay? So in a simple way, too much blood entered a dilated ventricle, sloshing sound in a failed heart is S3. Right? Whereas any stiff, non-compliant ventricle, if it is there, the atrium need to contract stronger in last 1/3. That lead to fourth heart. Is what you need to. Okay? Now, murmurs are very easy. They don't need, there is no rocket science in remembering and understanding them. They're quite easy. 1252. Okay. See, in cardiology, some areas require logic. So there I have to go slow. Am I too slow? Not too fast, right? Probably 30 years I am telling the same story. There are some of my students whose parents were my students, took coaching with me, and their children also are coming for coaching. I'm becoming ancestral endangered species. All right. Murmurs. Very simple logic you try to remember. You have what? How many types of valves? Aortic, pulmonary. Second, AV valves. And you have how many phases? Systolic, diastolic. Imagine there is a stenotic lesion in aorta or pulmonic valve. When the blood is pumped, will you have problem? That means ventricular systole. Or when the ventricle is getting filled, you are having a problem. If there is aortic stenosis or pulmonic stenosis. During ventricular systole, you will have problem, or ventricular diastole, you will have problem. ఇక్కడ stenosis ఉందప్ప. Simple. Think simple. When the ventricle is pumping into the aorta, that means ventricle is undergoing systole, then the stenotic valve will lead to turbulence in the blood and you listen the murmur. Clear? So that is the reason all stenotic lesions of the aortic and pulmonic valve lead to what type of murmur? Systolic. మళ్ళీ చెప్పరా? ఈడేముంది? మైటల్ వాల్వ్. ఈడేముంది? అయోటిక్ వాల్వ్. Right? When the ventricle is undergoing systole, the blood is gushing through a stenotic valve, leading to the turbulence. That lead to murmur. So, aortic stenosis or pulmonic stenosis, both of them are primarily what? Systolic murmurs. Clear? Then, if there is any stenosis in mitral valve, when the atria is moving blood into ventricle and ventricle is getting filled and ventricle is undergoing diastole, right? That is the time when the ventricle is undergoing diastole. That is the time where you are having the murmur. Okay? Yeah. There is a time where you have, but there is a consultation. What time? Huh? Okay. Just commit. 1 2 ki Kuda office for today. First starting day. మీరు రేపు రాగలుగుతానంటే కనుక నేను ఐఎమ్ అవైలబుల్ టుమారో, ఐఎమ్ జాబ్లెస్, ఐఎమ్ అవైలబుల్ ఎనీ టైమ్, బట్ నెక్స్ట్ సండే ఈజ్ కన్వీనియంట్. మీరు రాగలుగుతారా సాటర్డే కానీ ఎనీ అదర్ డే? సండే ఈజ్ బెటర్. संडे इज बेटर. खेलते खेलते February तक टाइम है ना, so playfully we'll finish. All right, just tell by 2:15. Commit. Now, where are we? Systolic murmur is over. Next entity. So when the mitral valve is involved, when the blood is flowing from atrium into ventricle, ventricle is undergoing diastole, filling, that is the time where you listen the murmur, right? So that is the reason mitral stenosis, tricuspid stenosis, they are all diastolic murmurs, whereas aortic stenosis, pulmonic stenosis, they both are सिस्टोलिक मर्मर्स. उतना तक क्लियर है. नेक्स्ट फिर बात करेंगे. वेंट्रिकल, लेफ्ट वेंट्रिकल फॉर एग्जांपल, pumped the blood into aorta. That means it undergone systole. End of the systole, what happened? Aortic valve closed. That time, then what happened? From atrium into the ventricle, blood is flowing. It is undergoing diastole. Right? During that time, the aortic whatever the blood pumped into aorta is regurgitating back into the ventricle. Correct? That's the reason aortic regurgitation occurs when the ventricle is undergoing diastole from the atria. That's the reason the aortic regurgitation, pulmonary regurgitation, they both are diastolic or systolic murmurs. Think coolly. There's no rocket science. Munda adarthamainda aortic stenosis, aortic stenosis, pulmonary stenosis are systolic murmurs. Mitral stenosis, tricuspid stenosis are diastolic murmurs. वो समझ में आए या नहीं? Tell me. और एक बार for you. इकडे ఉందండి mitral valve. ఇక్కడే ఉంది aortic valve. When the ventricle is pumping the blood into the aorta, the stenosis will lead to murmur. So aortic stenosis is a systolic murmur. When the mitral valve is stenotic, it is pushing the blood from atrium into ventricle. Right? That means ventricle is undergoing diastole. Hence, mitral stenosis is a diastolic murmur. Aortic stenosis is a systolic murmur. Clear? Now come to regurgitation. When will regurgitation occur? Ventricle finished systole, blood moved into the aorta, aortic valve closed, mitral valve opened, from atrium into ventricle diastolic blood is flowing, ventricle is undergoing diastole. During that time, whatever that is being pushed during systole will regurgitate back. Hence, aortic regurgitation is a diastolic murmur. Aortic stenosis is a systolic murmur. Mitral stenosis is a diastolic murmur. Okay? Inke undi mitral regurgitation. When will regurgitation occur? When will mitral regurgitation occur? From the left atrium into ventricle, blood mode, diastole. Diastole over. Mitral valve closed. Then the blood is moving into aorta. That means ventricle is undergoing systole. The pressure in the ventricle increased. And that pushed the blood back into ikkada, atrium. That's the reason mitral regurgitation occurred during ventricular systole. So MR is a systolic murmur. MS is a diastolic murmur. AS is a systolic murmur. AR is a diastolic murmur. Shanti. Huh? Feeling hungry? I know. ఈ టాపిక్ అయిపోగానే విల్ కాల్ ఇట్. కానీ ఈ టాపిక్ గుంజుతుంది. ఈ టాపిక్ అర్థమైన కార్డియాలజీ అర్థమైనట్టు. See, some concepts are such that first take, चलो भाई सुनेंगे, like periodic classification table. You are supposed to remember all periods, groups, elements, everything. Right? Okay. What are D block, F block, కొంచెం అర్థమవుతుంది. క్లాస్లో ఎవడో ఉంటాడు, వాడు ఏక సంధాగ్రహి, వాడు ఒకటే టేక్లో 120 ఎలిమెంట్స్ గడగడ ఆపేపుతాడు. అంటే his brain doesn't know analysis, he only knows how to reproduce like a Xerox copy. But that is not a creative brain, let me tell you. The brain which confuses The brain, which takes 2 to 3 times before fitting it into the brain, that is actually the most brilliant brain in medicine. Understand? So, what you need to do is first listen, इसका कितना दूर तक जा सकता ఏమంటే అక్కడ 4 చేంబర్లు ఉన్నాయి, 2 వాల్వ్స్ ఉన్నాయి, 4 వాల్వ్స్ ఉన్నాయి, 2 ఫేజ్లు ఉన్నాయి, డయాస్టోలి సిస్టోలి. పెద్ద దీంట్లో సోది ఏమున్నది? इधर से अमीरपेट जाना, अमीरपेट से इधर आना, इधर से कोटी जाना, कोटी से इधर आना, उतना ही है. तो उधर आगे बढ़ रहे हो या पीछे बढ़ रहे हो, बस. So now, aortic regurgitation is a diastolic murmur. Mitral stenosis is a diastolic murmur, whereas aortic stenosis is a systolic murmur. Mitral regurgitation is a systolic, tricuspid regurgitation systolic. VSD, ventricular septal defect, if it is there, same imagination, no rocket science. Okay? There is a septal defect. When the ventricle is undergoing systole and trying to push the blood into the aorta, this VSD is stealing that blood. Blood is moving through the hole into the right ventricle and also into the aorta. So VSD murmur is a systolic murmur. When the ventricle is filling from atria, there is no murmur in VSD. Only when the ventricle is pushing the blood with pressure into the aorta, that time it is leaking into the right ventricle through VSD. So VSD is also a systolic murmur. Then there is an entity called hypertrophic obstructive cardiomyopathy. పెద్ద పేరు. దీని సంగతి తర్వాత వద్దాం, ఇది స్పెషల్గా మాట్లాడుకోవాలి. సో చెప్పండి ఫాస్ట్ గా, వాట్ ఆర్ ద సిస్టాలిక్ మర్మర్స్ దట్ యు నో ఫటాఫట్? AS, MR, PS, sorry, AS, MR, TR, VSD, HOCM. Once more, AS, MR, TR, VSD, HOCM. These 5 are systolic. Then what are diastolic? AR, MS, they both are diastolic. बस अभी के लिए इतना समझ लो, बाद में पढ़ेंगे. Right? Now, what is a continuous murmur? It is starts in systole and continues into diastole. That is the nature of PDA. What is PDA? Public display of affection. PDA. PDA means from the right left ventricle ఏమొస్తుంది? Aorta. From the right ventricle ఏమొస్తుంది? Pulmonary. ఈ రెండింటి మధ్యలో ఒక తొరబొర టన్నెల్ ఫామ్ అవుతుంది. That is patent ductus arteriosus. The ductus arteriosus normally closes, but it does not. It does not in few people who have PDA. Because of that, how will the blood flow? High pressure in aorta, low pressure in pulmonary artery. Obviously, blood कहाँ से कहाँ जाएगा? From the left to right. And always remember, left to right are cyanotic. अच्छे लड़कियां गंदे लड़कों से मिले तो एक गंदा लड़का सुधारेगा. The chances that he can become better. ठीक है? But अच्छा लड़का गंदे लड़की से मिले तो, सॉरी, गंदा लड़का, ये लड़का है, pulmonary is लड़का, ये लड़की है. So always remember, aortic oxygenated blood mixes with deoxygenated Pulmonary, nothing will happen. Cyanosis will not be there. But the moment pulmonary artery deoxygenated blood meets the oxygenated blood, that leads to cyanosis. But in case of PDA, what is happening? Aortic blood is mixing with pulmonary artery. That's the reason there is no cyanosis. And this movement occurs during both systole and diastole of the heart because it is outside the heart. That's the reason it's a continuous murmur heard in the infraclavicular area. Right? Then there is a differential cyanosis when this PDA is associated with Eisenmenger. First of all, what is meant by Eisenmenger? Eisenmenger means what? Very simple. There are three lesions which are called cyanotic heart disease. What are they? ASD, VSD, and PDA. ASD, VSD, PDA. In all these three, what is happening in ASD? Left atrium blood is going into right atrium. Good mixing with the bad is okay. VSD, left ventricle into the right ventricle, good with the bad. Okay. PDA, aorta going into pulmonary artery, good with the bad. In all these three, what's happening? All the left sided blood is stolen into right side. Because of that, the right side pressures will increase. More flow is there. Regular venous return is coming into the right side. All this extra blood is coming from left side. Together, more blood in the right side. All that more blood will go into the pulmonary artery. That leads to pulmonary hypertension. The moment pulmonary hypertension develops, the right-sided pressures will be as good as left-sided pressures. So that will make all the blood go back from right into left. That is bad mixing with good. That will then lead to cyanosis. It's called reversal of shunt. Initially, ASD, VSD, PDA are all cyanotic. The moment that increased flow for a long period of time made pulmonary blood vessels develop hypertension, and the pressure on the right side increases, that will reverse the flow back from the right side into the left side across the ASD, VSD, PDA. That will make good blood mix, bad blood mix with good, leading to cyanosis. So cyanotic became cyanotic with the advent of pulmonary hypertension. In ASD, VSD, PDA is called Eisenmenger. Winner? Yes or no? 50%. Huh? ఏం లేదు తమ్ముడు, చాలా సింపుల్. ఏఎస్డి ఉన్నది, ఈడ విఎస్డి ఉన్నది, ఈడ ఒక హోల్ ఉన్నది, ఆడొక హోల్ ఉన్నది. లెఫ్ట్ సైడ్ ప్రెజర్ ఎక్కువ ఉంటుంది కాబట్టి లెఫ్ట్ నుంచి రైట్ గుడ్ బ్లడ్ బ్యాడ్ బ్లడ్ కలిసింది. మంచి చెడుతో కలిస్తే ఏం కాదు, నో సైనోసిస్. కొన్ని రోజులు గడిచింది. రెగ్యులర్గా రైట్ సైడ్ ఏమవుతుంది, రెగ్యులర్ వీనస్ రిటర్న్ వస్తుంది, మళ్ళీ మీదకెళ్ళి ఇది ఒకటి వచ్చి మీద పడుతుంది, అసలే ఉద్యోగం లేదు, మళ్ళా పెళ్ళి అయింది. దాంతో బీపీ పెరిగిపోయింది పల్మరీ ఆర్టరీలో రైట్ సైడ్లో. అప్పుడు ఏమన్నది ఇది రైట్ సైడ్, ఓ నా కాడ కూడా ప్రెజర్ ఉండదు బాయ్, నువ్వు ఇచ్చిన బ్లడ్ వల్ల నా బ్లడ్ వెజల్స్ అన్ని కూడా థిక్ అయిపోయి నా సైడ్ కూడా ప్రెజర్ బిల్డ్ అయింది, తోపులో నువ్వు నాకు ఇచ్చేది నేనే నీకు ఇస్తా పట్టు అని రివర్స్ కొట్టింది. కొట్టంగానే బ్యాడ్ వెళ్ళిపోయి గుడ్లో కలిసింది. అది చెప్పండి సైనస్ వచ్చింది. దాన్ని ఈజన్మింగర్ అంటారు. ఖతం. నెక్స్ట్, whenever a patient of PDA develops Eisenmenger, they develop a differential cyanosis. What is the meaning of differential cyanosis? Let us talk. You can see the lower limbs are showing clubbing, which is a sign of cyanosis. Upper limbs are not. That is called differential cyanosis. When will it occur? When PDA with Eisenmenger is there, it will develop. Let us look at the mechanism of why it happens. Right? Now, first, PDA is present. Because of that, from the left to right, blood is moving. That is from aorta into pulmonary artery. Clear? That will increase the pulmonary blood flow. That lead to pulmonary vessel to remodel. Media undergo hypertrophy. That lead to increased pulmonary vascular resistance and lead to pulmonary hypertension. That will cause the reversal of the shunt from right to left, leading to Eisenmenger. इधर तक आ गए? हाँ. So a shunt reversal caused right to left. So because of that, what happened? The deoxygenated blood of the pulmonary artery entered into the aorta. Where is the PDA located? Aorta on the aorta gives subclavian, which go to upper limbs. After that, PDA is located, ductus arteriosus, connecting the pulmonary artery. That means whatever this impure blood is entering from the pulmonary artery into the aorta is entering after the upper limb blood is gone into subclavian, which is oxygenated. That is the reason only lower limbs receive the deoxygenated blood. Cyanosis develops only lower limbs, not in upper limbs, which is called differential cyanosis or a pop. क्या तो बन गए पूरा बजा जा बालाजी ना ये मेडिकल कॉलेज है ममता पूरा ममता में only persons మీ పేరేంటి పర్లే పర్లే అరే మహేష్ బాబు నువ్వు Sharath is the top cardiologist in Hyderabad. Right. So, only two guys who know differential cyanosis mechanism. That's the reason when you go back to hostel, no? What is the best way to revise? Don't keep it to yourself. Another 10 sishyas, bitao, unko differential cyanosis ka lectures shuru karo. That's how you'll do revision. Remember that. Now, there is another entity called reverse differential cyanosis. Matlab, upper limbs lo cyanosis, lower limbs lo normal. Ikkada. Whenever transposition of great arteries is there, what is the meaning of transposition of great arteries? Aorta arises from right ventricle. Instead of left ventricle, it arises from right ventricle. And pulmonary artery arises from left ventricle. That's the reason aorta will be carrying deoxygenated blood. Pulmonary artery will be carrying oxygenated blood. In this situation, the only way to survive is PDA or ASD should be there. It should not be closed. Enduku? Because the aorta, which is receiving the blood from the right ventricle, need to have to transfer it back to right side using the PDA. So PDA जरूरत है. समझ में आ गया ना? So survival depends on the presence of PDA and AST. అప్పుడు PDA ఉందనుకోండి, what will happen? Anytime PDA is before origin of subclavian artery. So subclavian artery received the aortic blood coming from right ventricle, which is carrying deoxygenated. So upper limbs became blue, cyanotic. But the PDA helped the pulmonary artery blood, which is oxygenated, to come and mix with aorta and purified it. So lower limb receives oxygenated blood. Beautiful, no? Reverse differential cyanosis is a feature of transposition of the great arteries or any right-left condition, right? With the PDA, if it is there, you get reverse differential cyanosis. Whereas ASD, VSD, PDA with the Eisenmenger complex will lead to, PDA with Eisenmenger will lead to regular differential cyanosis. So that's the point, doctor. Upper limbs pink, whereas upper limb cyanotic in reverse. TGA plus PDA is reverse differential. PDA plus Eisenmenger is differential. Okay. All this video will be made available in the video library. You get an access, including the PowerPoint. Huh? Emma? It will be available in, we have a web portal called NEETPG.app. Okay. In that, they will give you access. So there you have the video library. Don't worry. Including PPT. Okay. This is another very important thing to understand, doctor. ఒక్కసారి HOCM అంటే ఏంటిదో అవుదాం. Then half the misery of the world is gone. I'm going very slow. This is not my speed, but I'm trying to make you life easy. Right? From left atrium, the blood through mitral valve will go into left ventricle. From left ventricle, it will go into aorta. And this is called LVOT. What is that called? And the left ventricular outflow tract is the name given. And what is this between left ventricle and here you have the right ventricle? You have a septum, interventricular septum. And what is this? This is the mitral valve anterior leaflet, and this is the mitral valve posterior leaflet. In few people, this interventricular septum becomes hypertrophied. It becomes so thick that this mitral valve anterior leaflet comes very close to this hypertrophied septum, that when the ventricle is undergoing systole and push the blood into aorta, this left ventricular outflow tract become blocked. ఇక్కడ ఫ్రీ ఉంది కదా స్పేస్, సో రన్వే మంచుకున్నది దీంట్లో పోవడానికి. కానీ ఈడ anteromedial leaflet and interventricular septum are coming and touching each other, and that lead to obstruction to the outflow of the blood. Normally, during which phase? During ventricular systole of the blood into the aorta. Am I clear? So, normally, in which condition this kind of obstruction to flow into aorta occur? If there is any aortic stenosis. But here there is no aortic stenosis. Aortic valve is normal. But where is the obstruction? Below the level of the aortic valve. That is the reason it is called subvalvular obstruction of the LVOT for the flow of the ventricular blood into the aorta is the HOCM. Am I clear, sir? Now, if the ventricular chamber size, assume, if the ventricular chamber size If it is small or if it is big, when will this touching will be more? Common sense. The touching between this mitral valve leaflet and this hypertrophied septum will be more if the size of this is small or bigger. పెద్దగా ఉందనుకోండి తాకాయి, చిన్నగా ఉందనుకోండి తాకుతాయి. A man touching a woman in a city bus will happen if it is crowded or if it is no passengers are there. Crowd. So anything that lead to smaller size, crowding will cause touching. Touching lead to obstruction to outflow, and that lead to murmur. So what type of murmur you hear in HOCM? Systolic murmur. But this is called a dynamic obstruction. Why it is called dynamic obstruction? In aortic stenosis, it's a fixed obstruction. Right? Because aortic stenosis is a fixed one. Here, suppose if this ventricle uses pressure and push the blood, no, this LV-OT will become, obstruction become overcome. Agree? Or if the filling of the ventricle is more, then if the size become increased, then also the obstruction will be gone. That's the reason the obstruction that you see in HOCM is called dynamic obstruction, not a static obstruction, unlike in aortic stenosis. Clear? Okay. Now, let us play the game. Anything that lead to a smaller chamber size will worsen the. Anything that make the chamber size become smaller will make the obstruction become worsen. Anything that makes the chamber size bigger will decrease. Now, first let us see. What happens when you do Valsalva? What is Valsalva? Forced expiration against a closed glottis. Valsalva. There are two things. One is inspiration of the air, other is expiration of the air. When you inspire the air, there is a negative intrathoracic pressure. That negative intrathoracic pressure will have a sucking effect, like you are drinking coconut water using straw. That will suck the blood from the great veins into the heart. And the filling of the heart will increase. Malla, come back. When you do forced inspiration of the air, negative intrathoracic pressure will create a negative sucking pressure that will bring increased venous return sucked from the great veins into the heart, and the filling of the heart increase. So what happens with a forced expiration against a closed glottis? Reverse. It will create positive pressure, not negative. That will prevent the blood sucked into the heart from veins. ఇంతకుముందు నెగటివ్ ప్రెషర్ ఇన్స్పిరేషన్ సక్డ్, ఇప్పుడు పాజిటివ్ ప్రెషర్ when you are expiring using Valsalva maneuver, decreased the sucking and decreased the filling of the heart. Because of that, the chamber size become smaller. If the amount of the blood coming from the great veins into the atrium, making atrium size smaller, filling of the ventricle becomes smaller, will make the ventricular size become smaller, and that lead to worsening or improvement of the systolic murmur. Smaller size, increase obstruction, worsen. Okay? What happens when there is a Valsalva maneuver? Positive or negative pressure? Decrease sucking or more sucking of blood into the heart? Decrease sucking. Decrease sucking will decrease size of the ventricle. That will increase or decrease the murmur? Increase the murmur. Increase the or decrease the murmur? Shanti. Clear? So Valsalva decrease the preload. HOCM murmur increase. But all other conditions where the murmur is caused by the flow across a stenotic valve, తక్కువ blood flow అయిందనుకోండి murmur తగ్గుతుంది for everything. But for HOCM alone, it will increase. Clear? Now what happens when you stand for long period of time? Your venous return decrease, filling of the heart decrease, chamber size of the heart decrease, that decrease the preload, and that is worsen the HOCM murmur. Squatting is opposite to standing. That will increase venous return, right? And that will increase most of the murmurs. Then what is hand grip? If you are doing hand grip, you are releasing catecholamines. That will lead to vasoconstriction. That will increase the afterload, right? What is the effect of increased afterload on HOCM Jundam? If you do hand grip exercise, what will happen? That will increase, release catecholamines when you are doing exercise. That increase systemic vascular resistance. That increase afterload. And the LV has to pump against, LV has to pump into the aorta against high pressure. Right? So what will it do to do that? Whenever the afterload increases, the inotropic state of the ventricle will increase. And what will it do? It will use more pressure to push the blood against a high afterload. Right? Appudu this small dynamic obstruction no more matters. When you are fighting against a bigger problem, smaller things really don't matter. Understand? So it will overcome the obstruction and the murmur will decrease. That's the logic. Understand? Hand grip exercise is like your MBBS final year exam was. All your systemic vascular resistance is increased. You are fighting against an exam. So you will use all your focus and attention to pass the exam. Earlier you used to fight on small things with your girlfriend. I sat here, you sat there. I read this book, you wear that pink color dress, I want you to wear. Chote mote cheezon, which is a fuel in romance. All that small things will be gone because you are fighting a bigger exam. After exam is over, once more you will start fighting on chilpish things. Right? So that is the point you need to remember. Hand grip increases the afterload and increases the inotropic state of the ventricular muscle so that this small dynamic obstruction no more matters and the blood gets pushed and murmur will decrease is what we need to remember. That is the story, doctor. Finally, how to differentiate right and left-sided murmurs? All the right-sided murmurs increase with inspiration. How will you remember that? What is the logic? When you're doing inspiration, there is a negative intrathoracic pressure, more venous return to the heart, and that will increase the right-sided murmurs. Okay? And there's a specialty for TR murmur. Is it right-sided or left-sided TR? Right-sided. So when you do inspiration, right, there is an increased venous return, which is trying to fill into the heart. Same time, regurgitant blood is also coming into the atrium, right? Together will cause the JVP get elevated significantly, and the murmur intensity also increases during inspiration, which is called Carvalho's sign. So during inspiration, there is a decreased interthoracic pressure, negative interthoracic pressure, increased venous return to right atrium, and that increases the right ventricular filling, increases the right ventricular stroke volume. More blood will be regurgitating across the incompetent tricuspid valve. That lead to more turbulence across the tricuspid valve when TR murmur become louder, which is typically called Carvalho's sign, is fortunate to remember. Now let us summarize, doctor. Elderly patient developed syncope and systolic murmur. Think of aortic stenosis. Aortic stenosis is because of the aortic valve calcification or bicuspid aortic valve, typically in elderly. So, whenever aortic stenosis is there, when the ventricle is pumping the blood into aorta, less amount is going, and that is less amount going to brain, leading to syncope. So, syncope is the hallmark of AS. So, elderly syncope with systolic murmur. Think of severe AS. Agreed? Now, a young athlete developed syncope, which is Valsalva is worsening the murmur. Think of HOCM. IV drug abuser murmur along with fever. Think of tricuspid endocarditis. Endocarditic vegetations also will create a murmur. So fever plus murmur is a classic of IE. After MI, if there is any murmur, think of papillary rupture leading to MR. In a pregnancy, someone has got a diastolic murmur. Remember, pregnancy low, systolic murmur is a normal thing. Systolic murmur can occur in anemia, pregnancy, volume overload states. But diastolic murmur always is abnormal. That is mitral stenosis is what you need to remember. Right? So, doctor, that brings us to there are a few more things we'll take up in the next class. Right? So, I hope you enjoyed 3 pages in here. Note of a page. But we will go much faster as we move forward because you guys are now slowly coming out of the digi spell about where is right, where is left of the heart. And I'm sure now you are much, much better. Am I right? Good. Thank you. So you are study group in the WhatsApp? No? Manu, include them. Yeah? I'll be posting audio mantras. I'll be posting a lot of things, freebies, right? So to inspire your preparation. I'll also give you the total list of high yield topics for all your final year subjects. Okay?